Bismillahirrahmanirrahim. The learning objectives of today's talk will be introduction, historic review of the back pain and sciatica, review of literature and pathophysiology of the low back pain and sciatica, suspected causes or proposed causes of low back pain, clinical presentation, investigations, ways of treatment, and take home message. The back pain is a so huge topic that I have to go very quickly and very fast. So you have to bear with me and you should be on your toes. Low back pain and sciatica. Low back pain is usually defined as a pain, muscle tension, or stiffness localized below the costal margin and above the inferior gluteal fold. If the pain is going down the leg, then is called sciatica. So these are the two things in one. Either you have low back pain with or without sciatica or separately. Back pain is an epidemic faced by the medical community since the recorded history of mankind. Surprisingly, at the same time, despite of all the progress and development, still the least understood phenomena with certainty. There is no agreement that how the pain is generated, where it is coming from. With the time, there are so many theories. I will go through each one bit by bit, and you will see that none of those theories or remedies or is absolutely right, or we can say the gold standard, or we can say the set standard. Though there are 101 causes, theories, remedies, claimed good results, but no agreement on one standard treatment or theory. Low back pain and sciatica prevalence is a leading cause of the activity limitation and work absence throughout much of the world, imposing a high economic burden on individual families, communities, industries, and the governments. Low back pain was identified as the most common cause of disability in the young adult. More than 100 million work days lost per year. It is not a serious illness. It is not a life-threatening condition. It's self-limiting most of the time. And I don't call it a disease. I call it a condition because it's not a disease, it's a condition. And surgery is not always needed, whereas there are a lot of undue surgeries going on. I'll go through in my coming slides and explain that why the surgery is not indicated all the time. It is indicated, but very small percentage of the patients. It is as common as flu, and it's only second to the headache as far as the pain is concerned. And sometimes it's painful like a piles and crippling as a stroke. And 4 out of 5 adults experience it in their lifetime. पीरी से खम नहीं कमर में ए कमर मैं झुक के ढूंढता हूँ जवानी किधर गई. For those who don't understand Urdu, because this is going live worldwide, and those who are unable to understand the Urdu, the translation is that in this poet says that I am bending forward not because of my old age, but I am trying to find out my youth, where my youth is gone. This is because Allah has given us a virgin spine, and the spine we have at the age of 40, we deserve it. So you can see on the screen that we got this spine, which is normal, but at the age of 40, due to the damage to the bones and muscles and or different sort of factors, it made it like this. So we deserve this. Now, taking the historic review of the back pain, as I said earlier, that the history goes back to the history of the mankind. It goes back at least the Bronze Age, 2000 BCE to 500 BCE, and Edwin Smith papyrus, which is 1500 years BC, describe it as vertebral sprain. So you can see that how old this condition is. I again say that it's not disease, it's a condition which we have adopted. Hippocrates also used the term sciatic pain and low back pain in 460 BCE. Bronze Age, as I mentioned earlier, and Edwin Smith papyrus is a 1500 BCE. It was the first textbook in surgery, the oldest trauma reference, and it is 5,000 years old. Stayed in the print form for more than 1500 years. Case scenario format, problem-based medicine, and the brief and birth of the analytic thinking in medicine. So you can see that now we say the evidence-made medicine, evidence-based medicine. So it's the same thing, which 1500 years BCE, Edwin Smith papyrus said that the difference of only the word, that analytic taking in thinking in medicine is same as today we say the evidence-based medicine. So it's a remarkable insight into the medical practice in the ancient Egypt. Acupuncture was a method of treating the back pain 6,000 years BCE, which is still going on. I mean, in some part of the world and even in Pakistan, this acupuncture is still in practice. Then 5th to 15th century, the evil spirits were suspected and the treatment was based on such beliefs. Hippocratic views were that it is related even to weather changes, more frequent in summer and autumn. He also mentioned it's more common in the social class. So today we see the same thing, that a laborer will not have back pain, while the office worker or bureaucrat or the person who is not doing much physically, he has more back pain comparing to the laborer or villager. He even related it with the evil spirit and sins. He was the first one who stressed to know the anatomy for the understanding of the disease. As if we don't know the structure of the spine, we have the facet joint, we have the disc, we have the vertebra, we have the ligaments. So if we don't know, so it is difficult to know where the pain is coming from. And even I say that even after knowing all these, still we are struggling that where the pain is coming from. He also suspected that the hip joint disease is the cause of the sciatic and back pain, which is later on it got cleared that it is two separate entities. Romans also related it with the gout, poliomyelitis, tuberculosis, and hip dislocation. Look well to the spine for of disease. This was saying of the Hippocrates. Inversion therapy, 400 BC, this method was used to treat the back pain, and now still in the USA, there are some modern inversion equipment which they just tie the patient to that device, and they do it upside down. So it's still available in the United States in use. Galen in 2nd century, he described the back pain in depth in the late 2nd century. Watchful waiting was the treatment till the end of the first millennium. And I think this is the best treatment, which I also follow that treatment, that you will see in the coming slides, that the first method of the treatment is that take no treatment at all, just watchful waiting, and it will end. As I said before, that is a self-limiting condition. So he also used this method, that watchful waiting was the treatment till the end of the first millennium. He observed the abnormal spinal posture, lordosis, kyphosis, and attempted to correct it with the different devices. He also used the bloodletting to treat the sciatica, to remove the noxious humors, as he was suspecting it the cause of the disease. And even today, in Pakistan, the bloodletting is still going on. And I have seen many patients who have gone through this treatment. And you will see in the coming slides that this practice is going on. Bloodletting. These are the instruments which they use for the bloodletting in the 16th and 17th century. They were suspecting that there is noxious material in the veins and they drain it and the patient get relieved. This is the picture which I saw the patient in my clinic, and this is the huge list of the drugs which he used. And these marks, you can see the bloodletting marks. They are healed now. Back therapy in the 5th century BC. So very cruel method of treating the back pain like this. But if you think that in our villages, our old people, they ask the small child to walk on the back as a remedy of the back pain. So it means that still it is used in our villages, and the old people used to say, though it's a dangerous thing, but still in practice. 19th century, the lumbar disc pathology and vertebral column took a pivotal role in the etiology of the back pain and sciatica. It worked as a foundation for the modern way of approaching the back pain and sciatica. They observed lumbar disc herniation, protrusion, and cord compression during the autopsies. So from the 19th century onward, we are becoming little bit scientific and thinking on scientific basis rather than blaming the sins and evil spirits and other causes of the back pain. Straight leg raise as a stretch test, sciatica, scoliosis, spinal nerve irritation, degeneration, trauma, laminectomy, all were described in the 19th century. Chiropractic is very popular. Still, it is practiced in UK and other countries. Here we also have this practice. We can call it these Malishi or Palwan or different. Traditionally, they give different names to this chiropractic. Osteopathy is the same thing, just different names. First laminectomy was performed in 1887 by Victor Alexander Haddon Horsley, a professor of surgery at University College London. And Schmoll in 1925 described the pathology of the prolapse and degeneration of the nucleus pulposus. In 1927, the degenerative changes in the intervertebral foramen causing the nerve root compression was suspected for the sciatica. New theories emerged in 1920s and 30s, and nerve weakness, psychological disorders, injury, rheumatism, fibromyalgia were suspected as the culprits of the low back. Involvement of spinal canal by Mexter and Barr was presented in 1933 in New England Society, and then it was published in 1934. This was the start of the new era of the surgical options of the disc pathology that is prevailing till today. And personally, I think that was a misguidance. I will call it misguidance that due after this paper and surgical ratio of the comparing to the conservative method increased. Undue surgeries, I will say undue surgeries, those surgeries which could have been done, handled conservatively, were carried on. And they were credited for the describing the relationship between the disc and sciatica. In 20th century, the terms neuralgia and neuritis were used in early 20th century. William Harvey Cushing, an American neurosurgeon, promoted the surgical treatment for the low back pain. The use of X-ray and diagnostic tools, intervertebral disc was blamed for the back pain. With the arrival of the CT and MRI, resulting in the surgical treatment over nearly the half of the century and still in practice. Research did not prove the disc as a sole cause of the back pain, neither the surgical treatment as a sole remedy for the back pain and sciatica. But as I said earlier, that we see the bulging disc on the MRI and we suspect it and we remove it. Whether it rather it should have been done conservatively. With the advancement of the microdiscectomy and endoscopic discectomy are now widely in practice to address the disc pathology. Even the biological treatment is emerging like a stem cell and uh, other methods of the using the biological treatment. But still it is not proved that whether it works or it is still just like a placebo. We have to, and if you see, there are so many remedies, which means that nobody understand what the back pain is. If there was a clear cut reason for the back pain, there should have been one or two treatments, but there are so many treatments in the history. I have taken you from the stone age till 20th century, and none of the remedy or treatment is a gold standard. Let's see what the literature says. Review of the literature and pathophysiology. Rupture of the disc, as you have seen in the previous slides, that Maxter William in 1933 presented a paper in the one of the conference, and then it was published. So Cochrane review between the 1999 and 2002, disc prolapse. There is a considerable evidence of the clinical effectiveness of the discectomy for carefully selected patients. The word carefully selected patients with the sciatica caused by the lumbar disc that fails to resolve with the conservative management. Whereas I have seen that without going to through the conservative treatment, you see the disc bulge, and patient says that the pain is in the lower back, radiating down the leg, and we correlate that disc bulge with this symptom, and we go for the surgery, which is not right. So this paper says that surgery should be only for those which are not responding to the conservative treatment. For that, understanding of the natural resolution of its failure is important, that we should see that how the disc degenerate and what is the outcome. Looking back on the back pain, there was a review of more than 5,000 issues and more than 450 articles in the 100 years of the German literature, and it clearly says that in the beginning of the last century, many etiology coexisted, which you have seen, and I have gone through those. But in the second half of the century, the disc degeneration took over almost the entire literature about the back pain. So these 2D, I call it 2D, disc and degeneration. This took at least half of the century, and it and tendency to prefer the organic and visible abnormalities as etiologies rather than relying on the clinical examination or history. An inclination to trust the technical diagnostic results more than the clinical judgment. So as we move forward, we are relying more and more on the technology rather than our clinical skill, which is not good for the patient and not good for the community. Pathoanatomy of the back pain. Pathology and pathogenesis of lumbar spondylosis and stenosis, as I said, it's in the paper of the correctly Willis. It says that progressive changes in the joint and disc entrapping the nerves. But this paper has severe limit, no time frame for these changes. So as you know that these degenerative changes, we have no time frame in how long it will take. It depends on the condition, and no pathophysiological study and no consideration for the natural resolution. This is the crunch slide to understand the back pain. The spine, we have the three giant complex. That's a facet giants and intervertebral disc, disc above and disc below. And we have two pathways. One is the intervertebral disc, it's radial tear and circumferential tear. It goes into disc bulge and herniation. And the second one is the posterior joints, which is facet joints. That's synovial reaction, and it is cartilage destruction, which leads to the osteoformation and capsule laxity. So if that capsule laxity and their height of disc due to the bulging or herniation, the spine got instability. And if you go further, if you don't stop it, these changes here, so the lateral nerve entrapment occurs. As you see that the foramen get narrowed, and due to the disc height and plus the osteophyte formation plus the ligamentum thickening, so we get the central stenosis. If the level is single level, we call it one level central stenosis. If there are multiple level, then it is we call it multiple degenerative lesions. So as you see here, it's a normal disc here, and it's a intradiscal degeneration started here, and you see the herniation here. If you see this is normal disc, is herniation started here, and then sequestration, and you can see here this white dot. This white dot is a radial tear, and all pathology started from this radial tear, and then sequestration and degeneration of the joint. Radial tear. This is radial tear. This is white here. Radial tear. Natural recovery rates of the low back pain. Widely held belief is that 80 to 90% of the attacks of the low back pain recover within 6 to 8 weeks, irrespective of the intervention, whether you go for surgery or whether you go for physiotherapy or whether you go for no treatment or whether you go to the shrine or whatever you do, it gets settled down in 6 to 8 weeks. And 90% of the patient will have stopped consulting their GP with the symptoms within 3 months of their first symptom. Clinically, staging of the sciatica. We have 3 stages of the sciatica. In the stage 1, the nerve gets sensitized because of the disc bulge, or sometimes there are chemicals irritation from the radial tear. And in the second stage, the nerve mobility get mechanically compromised, which we can check by SLR, straight leg raising test. And third stage, the nerve dysfunction detected by the routine sensory and the motor evaluation in the electrophysiological study. There are I'll just go quickly through these, some literature. If you see, this is another slide where you see the disc herniation, and this is the nerve coming, and this is the distal end. So if you see here, there is a bulge, and in the initial state, it is compressing slightly, and then slowly and gradually it compresses the nerve more. So it will result in 2 pathways. Either the nerve will get ischemic due to hypoxia, or the nerve will get the fiber injury. Both leads to the local demyelination and edema. If it is ectopic discharge, the root pain only the sciatica, that is neuropraxia. But if the wide demyelination occurs, it may do the sensory changes or weakness or root pain or foot drop. So the axonotmesis and neurotmesis can occur. So this is the crunch slide of the disc herniation. Depends on how much disc is herniated and how much the nerve is compressed. Sometimes there is no disc herniation, but there is radial tear, which excrete the chemicals which irritate the nerve and cause the tingling sensation or some motor or sensory changes along the nerve. These are the chemicals which I explained in the previous slide, that due to radial tear, there is no disc bulge or no herniation, but there is radial tear, and there are cytokines which is nitric oxide and PGE2 and other inflammatory agents. So they go to three pathways. The proteoglycan synthesis is decreased and matrix degradation is increased, which leads to the net loss of the proteoglycans and this degeneration causing the low back pain. Whereas the direct stimulation and sensitization of the nerve endings, and it is also cause the low back pain. And if the direct stimulation and sensitization of the root ganglia and the spinal nerve root, then it causes radiculopathy. So this is sometimes the only findings on the MRI will be the radial tear. There will be no disc bulge, no sequestration, but the patient will have radiculopathy due to, and I've seen so many such patients here and abroad also, where the scan look normal except radial tear, and the patient gets severe pain going down the leg. Chemical mediators, there are three groups: the prostaglandins and leukotrienes, interleukin 1 beta, and tissue necrosis factor alpha. Pain is inflammation and inflammatory response is a law of pain. Over reliance on structural investigation as scan to explain the pain is unwarranted. As I said earlier, that the scan will be normal or maybe the only radial tear or just a tiny dot, white dot, but to otherwise there is no bulge, and we'll say that it's normal. But the chemicals are causing the pain, which is called chemical sciatica or non-compressive sciatica. And only targeting the prostaglandin gives a limited relief, reflecting the negatively on our ability to relieve the pain. So we should concentrate on all these three chemical mediator. There are some more papers from the literature. I'll just quickly go through. And key findings of these is that herniated nucleus pulposus contain the biologically active 17 kDa manometer of the tumor necrosis factor A, nerve root injury, and the pain is caused by this tumor necrosis factor. And inflammation is caused by tumor necrosis factor is an important mechanism of the radicular pain. Some more papers in the history. Tumor necrosis factor, all these I explained earlier. Sciatica biological management. Sciatica can be managed by medicine alone. Days are ahead when the surgery will only be indicated in the cauda equina lesion. Selection of the cases is important to avoid the adverse events. As I said, that 90% of the patients will get treated by conservative or non-surgical method, but there should be a very selective, I think, selective cases that we should label it for surgery, because these MRI and CT scan, and they are misleading. And I ask my patient, that those who request for the MRI scan, I say that if I request 10 people with no symptoms of the back pain, no sciatica, and do this MRI, 7 out of 10 will have the findings in the MR scan, whereas the patient has no symptoms at all. Biological management of the spondyloarthropathies as an extension. Nobody knows the exact cause of the back pain, but there is a huge list. There is a huge list of the causes of the back pain, suspected or proposed. Endless list of the different suspected causes, including even the devil's involvement. And doctors rarely be able to make the diagnosis, and they call it non-specific low back pain. Most of the causes need the patient attention. I'll go through the causes in a coming slide, and you will see that there is a more role of the patient rather than a doctor to treat that causes. So patient related and doctors help is rarely needed, and very rarely need the consultant help, because it can be easily managed by the patient himself, or the doctors. So you see, this is endless list. There's a lack of or unaccustomed exercise, obesity and overweight, footwear, furniture, smoking, pregnancy, improper way of lifting, improper carrying, improper sleeping posture, school bags, lying on the ground. And it is very interesting that some patient, if the patient get back pain, we ask them to lie on the ground or on the hard bed, which is totally wrong. So this is rather giving more pain than a relief. Similarly, depression, anxiety, joblessness, stress, tension at workplace, sedentary lifestyle, poor posture, prolonged use of the computer, sitting, and even now there's a new term, text neck. Text neck is that those who use the mobile phone for a long time, and so their neck get pain. Similarly, as we get the leg back pain while we are sitting on the sitting for the computer, launching forward. So, and similarly, the prolonged driving and activity resulting in the stress on the spine and sleeping disorder. So you see, these are all the causes related to the patient. So this is just quickly visual causes, because they say that picture has more effect on the than the words. So this is the sedentary lifestyle, overweight, pregnancy, poor posture. You see, this is a good posture here, whereas this is head is forward and thoracic kyphosis, it's an increased lumbar lordosis and sway back. So these all the postural reasons for the back pain. Same here, furniture looking good, but it's not adopted to the posture of the those who are using it. Lifting again, smoking is also a cause of the back pain, and even in America, some surgeons, they do not operate on the back. Those who are in habit of smoking, though in UK the NICE study says that it should not be, the smoker should not be deprived of the surgery for the back. Depression again, footwear. Now, do you think there is any role of a doctor in the above mentioned suspected or potential causes of the back pain? The answer is big no, because the causes you have seen so far, there is no role of a doctor to correct it. The patient has to correct by himself. Now, coming to the causes in the back, in the spine, where the doctor can help. For example, the injury, which injury to a disc or vertebra or ligaments or joints, and deformity, congenital or post-traumatic, disease such as cancer, HIV, tuberculosis and others, degeneration, that is spondylosis, prolonged use of the medication, steroids, which can result into the pathological fracture, yeah, osteoporotic fracture, gynecological and neurological disease. So these are the causes, these are the factors where the doctor can help the patient in. But in the previous causes which I have shown, this is just to the patient related. Now, coming to the triage of the back pain, we can divide the back pain into the four broad groups. Number one is the simple back pain or lumbago. Second one is the nerve root or sciatica. Third one is the serious spinal pathology. And fourth one is spinal emergency or cauda equina. So we see any of these four categories, whereas the first two, majority of is the first two categories, and there is a very few cases of the third and fourth categories. I'll go through one by one. Now, before going to that one, I'll just show you that the anatomic structure from where the pain can come. So the low back, if there is a low back pain, the outer annulus fibrosus and anterior epidural space and the inflamed, occasionally the facet joint, capsule and vertebral end plate. These are the causes of the back pain anatomically. In the buttock pain, annulus and compressed nerve root simultaneously, whereas the sciatica, there is a compressed, stretched, or inflamed nerve root. As I said, that it will be compressed when there is a disc bulge, it is stretched when there is a loss of lordosis or increased kyphosis or lateral bent in scoliosis. So if that occurs, it is pain will be due to the stretching, and that will result in sciatica or inflamed nerve due to inflammation, or as a chemical sciatica or non-compressive pathology. And if there is a pain in the knee or heel, that is inflamed nerve. So these are anatomical reasons of the pain in the different areas. So you can easily suspect that from where the pain is coming from. Now the simple back pain or lumbago, this is a mechanical in nature and varies with the physical activities, whereas it affects the lumbosacral area, buttocks and thigh. And the age group is 20 to 55 years of age group. They get this simple back pain. Prognosis is very good, and 90% of the acute attack settles in 6 weeks, whereas the 60% one recurrence within next year. Simple back pain, it gets resolved within 4 to 6 weeks if treated by the general practitioner. But if the treated by consultant and specialist, it take only 30 to 40 days with a much more cost of the patient. So did you get the message from this slide? Did you get the message from this slide that it get resolved in 4 to 6 weeks if treated by GP, but it get resolved in 30 to 40 days? So it's the same thing, but with much more cost to the patient. As the if the patient comes with a simple back pain to the consultant, he will do the X-ray, he will do the MRI, he will do different things. So the result will be the same. Result will be the same, that pain will resolve within 4 to 6 weeks or 30 to 40 days, but he will have to pay more cost for the investigations. So it is better to not go to the consultant and treat it himself. What to do? Hot water bottles or ice pack for 10 to 15 minutes. Changing posture every 15 to 20 minutes, as I am doing it now. Gentle exercises or stretches. Try to be active as much as possible. Paracetamol 500 milligram every 4 hours if needed. And avoid the extreme position like hovering and bending. If the pain is constant and not settling in 1 to 2 days, then need a general practitioner, not a specialist, because the general practitioner can treat it easily to avoid the extra cost to pay to the consultant. Don'ts of the back pain: no bed rest more than 24 to 48 hours. And I have seen the prescription of even professors that they have written that bed rest for 2 weeks, bed rest for 1 week. And this even they not more than 24 to 48 hours is like a disability. I will not call it a bed rest. I never recommend the bed rest as a treatment. I ask them that if you cannot move out of the bed, so okay, you can stay in the bed, but it is not a remedy, it's a disability. But it should not be more than 24 to 48 hours. And there should be no lumbar support, kamar band. There is no lumbar support at all. It weakens the muscle rather than giving the pain, giving the relief from the back pain. And no off work more than 1 to 2 days if cannot go. Preferably, you should not take any day off, but if you can't go due to the pain, you can take 1 or 2 days off, not a week. Second type of the pain is the nerve root pain, or we call it sciatica. It is unilateral leg pain more than the back pain. So sometimes patient will come and will tell you that I have back pain and leg pain. So the question should be, your back pain is more or leg pain is more. So if the leg pain is more, then it is sciatica. And there is numbness and paresthesia in the same direction, radiates to the foot or toes, and less than 5% of the back pain patients. Sciatica is commonly refers to the pain that radiates along the sciatic nerve distribution and is typically felt in the rear down back of the leg and possibly to the foot. This is the disc bulge here, and this is a nerve, so it is compressing on the nerve and causing the sciatic pain. Condition resembling the sciatica, there are a couple of conditions such as piriformis syndrome, sacroiliac joint dysfunction, spondylolisthesis, and spinal stenosis or arthritis. So clinically, when we examine the patient, we can differentiate between the sciatica and these conditions, as there will be a different sign and symptoms of these conditions comparing to the nerve root compression. Nerve root pain, primary care management is the prognosis is reasonable if no severe deficit, 50% recover in 6 weeks, and urgent referral or severe, if there is severe or progressive weakness, then it should be urgently referred to the consultant or to the nearing hospital. And recovery rate is slower than the simple back pain. Third is the serious spinal pathology with the red flags, that if the age is below 20 or above 55 and they say the localized pain in the back, so you should thoroughly investigate that patient, because in non-mechanical pain, and it is mostly in the thoracic rather than the lumbar, and they give you the history of the carcinoma or steroids or HIV, and patient will be unwell and there will be weight loss and structural deformity if they come late with the kyphosis and gibbous. Less than 1% of the back pain people will get this. So as I said, the first two categories, the simple back pain and sciatica, is the crunch of the number of the patient, whereas the serious pathology and the cauda equina are less. And this is the blessing of Allah. Cauda equina syndrome, it's an emergency. It is an emergency, and it can be caused because of the prolapsed disc or fracture or cord compression tumor. So these three conditions can compress the cord and result in the cauda equina syndrome. Cauda equina syndrome it requires urgent surgical decompression. In the first two categories, you should get an opinion from the different doctors. It's okay, because some will go for surgery, some will not. But in the cauda equina syndrome, the surgery is the only option. And you see here, this is a huge disc bulge, and it's involving obstructing the whole spinal canal, and it needs a decompression urgently. Spinal emergency is a bladder dysfunction, saddle anesthesia, poor anal tone, and maybe foot drop. So these are the signs where you should not wait. You should not wait for the conservative treatment, and it should be done in the good center, not in the middle of the night. This is the saddle anesthesia, and this you can see more than 75 or 80% of the spinal canal is compromised. Investigation. No investigations are needed for the diagnosis of the low back pain and sciatica. To be very honest, it can be diagnosed only on the history and examination. But we do the X-ray, we do the MRI, we do the other tests. But that should have some reason. If you are planning for the surgery, if you have decided that this patient has compression of the nerve root L4, L5 or L5S1, and then you want to plan for the surgery, then you go for the X-ray and MRI and blood test. But just for the diagnosis, those people who are doing the MRI for diagnosis is wrong, because the MRI gives the false positive findings, and there are so many studies. You can see so many studies that confirms that MRI gave the false positive results. If you see this slide, in the disc bulge is asymptomatic people, and 53% of the patient shows a disc bulge, while disc protrusion is 37%, and disc degeneration and extrusion, you see 63%. So you can see how huge number of these false positive MRI. So how you can rely on the MRI, and if the patient is a little bit shaky and saying that he had numbness and some, unless you don't have the neurological objective finding, you should not go for the surgery. You see the proposed remedies. I don't want to go into the details because the time is short, but you can see the bed rest, the heat, the diathermy, the even the exercises, leeches, spinal manipulation, cupping, spa, all these are the proposed treatment. But I will go through the 8 proper ways of treating the lower back pain, which I also follow. There are only 8 ways. Number 1, do nothing. As I said before, that do nothing, it will settle down on its own. And if it is not settling, then you can take the help of the medicine. The third is the physical therapy, acupuncture, or chiropractic. I don't do the acupuncture, but chiropractic is the job of the physiotherapist. And spinal injections and minimally invasive spinal surgery is getting popular. Then microdiscectomy, then laminectomy, and spinal fusion. So this is the list. This is the crunch slide. You can concentrate on this, that you should follow this sequence, that to treat the low back pain or sciatica. The only exception is that if there is a worsening neurology, then you can, yes, you can skip and you can directly go to the laminectomy or discectomy or whatever. But if there is no neurological findings, objective findings, not on the patient saying that he has tingling, he has this, but if you say that decreased sensation, poor anal tone, or absent jerk or something, only then you can jump to the this 7th one. Otherwise, you should follow this sequence. Do nothing, as I said, that encourage the normal routine activities. Pain hurts, but it is not harmful. Use it or lose it. Your muscle will get lost if you don't use it. So the motion is a lotion for the back pain. So if you remember, remember this thing, that motion is a lotion for the back pain. So you will ask the patient and encourage the patient to move rather than go to the bed. Medication, starting from the simple analgesic, muscle relaxant, and non-steroidal anti-inflammatory drugs, then neuropathic pain analgesics, and vitamin B complex, particularly the B12. And I have the personal experience of using the B12 in many patients. And this also is help in 2 ways. Help in the regeneration of the nerve, and it reduces once the nerve is regenerated, and so there is a decreased need of the analgesics. So you can use in most of the patient, vitamin B12 will help. Antidepressant and opioid analgesics. So this is the second method. Third is the physiotherapy. In physiotherapy, you can have the cold and hot packs, gentle exercises, stretches, mobilization of the neural tissue or the trigger points. Be active and move around if possible, because movement is life and rest is death. So if you remember in the previous slide, you remember motion is a lotion for the back pain, and here movement is a life and rest is a death. Acupuncture still used in the some areas. Sauna bath is a physical, is a heat or hot pack you can use. If you see, it was used in the old age and now Stone Age, and now we can use it in a modern fashion. Cupping still going on in some area of the country. Also in Islamabad they do that, but very painful. I don't recommend that. Fourth is the injection. And injection may be the epidural injection, facet joint injection, nerve root injection, nerve block of the ganglion. So different type of injection. So this is the 4th type of the treatment. Minimally invasive spinal surgery. So with the help of endoscope, you can see this endoscope, and you go laterally and you do. This is me doing the surgery in the Innsbruck, Switzerland. The positive message of the minimally invasive spinal surgery, that awake and aware straight surgery with the precise targeting of the pain. Because if you do go for the open surgery, there is a big incision, there is a damage to the nerve, damage to the muscles and bones. But here, patient is also awake, and it's a reduced surgical corridor. So it is getting popular day by day, and it's you can target the tissue which you remove, that a disc. But again, I will stress that this is the only 10% of the patient, those who need a surgery. 90% of the patient will not need a surgery. Sixth is microdiscectomy. Seventh is decompression and laminectomy. And eighth is the fixation. When all the remedies are failed, then we go for the fixation. If you have hammer in the hand, everything is a nail. So as I said that here, nobody is using the list of the no treatment and conservative treatment and medicine treatment and this and that. They directly see the MRI and they go for the laminectomy, as you see here. Sciatica is a biological management. It's a new way of treatment that can be managed with the medicine alone. And days are ahead when the surgery will only be indicated in the cauda equina lesion, as I said earlier. So selection of the cases is important to avoid the adverse effect. Biological management of the orthopathies is an extension. Natural recovery, low back pain, heal 6 to 8 weeks, as is a previous slide. So we'll just quickly go through that. Surgical and conservative method, though the surgery will give you the functional recovery is quick, but at the end of 2 years, the result of the surgery and non-surgery will be the same. Early intervention can prevent the back pain, as a back pain causes fear and avoidance of works and psychological distress and chronicity. So you can stop the acute pain going into the chronicity. Conclusion: we still do not know the exact cause of the back pain. So if those who are not concentrating or those who join late, so if you see only this slide, they will get the message that we still do not know the exact cause of the back pain. None of the treatment in the practice can claim the only or standard treatment for the back pain. Modern imaging is taking us away from our clinical sense, and sciatica can be managed conservatively in the majority of the cases, but the MRI findings pushes for the surgery. Days are ahead when the surgery will only be indicated in the cauda equina lesion. Selection of the cases is important to avoid the adverse events if going for the surgery. And regarding the biological treatment, one should not say that this is the only solution. We should also wait and see their results. The field is still open for us to explore. And take home message: if you just take these 2 3 things, I will say that I have done my job, that no investigation is needed for the diagnosis of low back pain and sciatica. MRI gives the false positive results. Surgery is not always needed. More than 90% of the cases can be treated conservatively, and just suspecting 2Ds, that is disc and degeneration, and doing discectomy fixation is not a solution. Still, there is a need of explore to more understanding to bring the standard way of treatment. References, these are the references. Whatever I have said, all is through the literature. You can search these references. And thank you very much.